Severe anemia is common among children in sub-Saharan Africa. It affects up to 15% of children admitted to hospital and can cause serious complications and deaths. It is usually treated with blood transfusions, but there's often more demand for blood than supply. Because of this, World Health Organization guidelines recommend conservative blood transfusion strategies. They recommend giving blood to children with haemoglobin less than 4 grams per decilitre or 4 to 6 grams per decilitre with complications, but not giving transfusions to children with uncomplicated severe anemia with haemoglobin of 4 to 6 grams per decilitre. Children admitted to hospital in Africa with severe anemia have poor outcomes. Studies suggest that around 1 in 10 die in hospital, and another 1 in 5 die or are readmitted to hospital in the 6 months after discharge. Importantly, guidelines do not say anything about how to monitor children with uncomplicated severe anemia during their hospital admission, either clinically or using repeated haemoglobin tests to see whether they should subsequently get a transfusion. The TRACT trial tested different transfusion strategies that aim to reduce mortality and morbidity among children with severe anemia in Uganda and Malawi. One question was which children need an immediate transfusion. Under current guidelines, children with uncomplicated severe anemia do not qualify for an immediate transfusion. But would they benefit? 1,565 children aged between 2 months and 12 years with uncomplicated severe anemia were randomly assigned to receive either an immediate blood transfusion or no immediate blood transfusion. The primary endpoint was mortality at 28 days. Children in the immediate group received a transfusion on average 1 hour after enrolment. Children in the no immediate transfusion group were monitored carefully for complications, both clinically and with haemoglobin tests every 8 hours in the first 24 hours, and then daily. If they developed a new severity sign or their haemoglobin dropped to less than 4 grams per decilitre, they then received a transfusion, making this a triggered strategy. While in hospital, 49% of the children in the no immediate transfusion group did indeed develop new severity signs of complicated anemia, or their haemoglobin dropped to less than 4 grams per decilitre, triggering a transfusion. These transfusions occurred much later than in the immediate transfusion group, on average 25 hours after enrolment. TRACT found no evidence of differences in 28-day mortality, 180-day mortality, or readmissions to hospital between the immediate and no immediate transfusion strategies. Haemoglobin recovered faster in children who had immediate transfusions, but by 180 days there was no evidence of difference between the two groups. The no immediate transfusion strategy reduced blood requirements by around 60% compared to immediate transfusion in uncomplicated severe anemia. Children in the no immediate transfusion group stayed 1 extra day in hospital on average. The no immediate transfusion strategy was less costly than the immediate transfusions, despite the longer stay in hospital. These results suggest that current WHO guidelines for children with uncomplicated severe anemia are correct. These children do not require an immediate blood transfusion as long as they are carefully monitored. This strategy can reduce costs and blood requirements. Implementing this strategy safely requires that regular haemoglobin tests are carried out throughout the hospital admission to identify children who go on to require a transfusion. This monitoring may help improve outcomes for children with severe anemia.